This morning, we are pleased to have with us Jessica Hamlin, who is with Meridian Health Center, or Health Services, sorry. She's going to be speaking to us about the Connexxions program and also about dual diagnoses in individuals with IDD. So Jessica, I'm going to go ahead and make you presenter. And we will take questions at the end, so you can type those in the chat box. And when we get to that point, Jessica, I'll read those out for you so that you don't have to worry about trying to read them, and I'll answer the questions, or I'll type in the answers as well. And just for housekeeping purposes, to let you all know, we do not send out certificates for attendance for this webinar, but you will get a thank you for attending that will serve as your proof. So Jessica, it's all yours. Oh, you're still muted.
Thank you. Are you guys seeing the slide, or I've got two monitors, so I just want to make sure which monitor you're seeing.
We see a very small version of your PowerPoint.
Okay, let me see if I can switch this over. Okay, well, hold on, give me 1 minute. I'm gonna change the way that I'm doing this, so hopefully that will make it so we can see.
Now we see it perfect. But we're not hearing you. No, we can't hear you, Jessica. I'm not sure what's going on. Sorry for the technical difficulties. Jessica, if you can go back to your other way you were doing it, I have the PowerPoint up and I can run your slides for you. If you want to try that. Did we lose her? There's new presenter.
Okay, I think I can hear again. So hopefully that means you can hear me now as well.
Yes.
Oh, good. I don't know what happened. I'm so sorry. If you want to make me presenter again, I think I've figured out how to do that. So I'm so sorry.
Okay. All right. Give me 1 second here. Ah, that's not what I wanted to do. Let's try this again. Okay, we've made you presenter.
All right. How
Hey,
about
we
that?
hear you too.
Hear me and see the slides?
Yes.
Awesome.
Yay.
All right, so like Amy said, I am Jessica Hamlin. I am the director of our Connexion services here at Meridian Health Services. I'm really excited to get to talk to you guys today about my passion, which is services for the duly diagnosed. So we're going to hit on lots of different things about IDD and mental illness and COVID and vulnerabilities to mental illness, and try also to give you some strategies for helping families to recognize that maybe they need some mental health services. And then I'm going to talk to you about this amazing program that I get to run. The idea of dual diagnosis kind of came around by a man named Frank Mendelocino, and it started in the late 1970s, like 1977 is when he first coined the term dual diagnosis, which is kind of a misnomer, right? Like, we know that most of our individuals have more than two, right? Duals too, but our individuals tend to have some type of intellectual or developmental diagnosis, as well as a mental health diagnosis, as well as some physical health diagnoses, as well as some social impairments. So we've got multiple things going on. Also, sometimes when you hear dual diagnosis, people are actually talking about the co-occurrence of mental illness and substance abuse. So it's a term that gets used for a couple of different things, but today we'll be kind of just focusing on that intersection of IDD and mental illness. Not to say that we can't, but really, sorry, what we should be doing is making sure that we're taking into account the entire experience of the person and everything that's going on with them, and that may be impacting their overall wellness. Another important thing about this dual diagnosis work is that we really need to look at all of the things that are going on, right? We can't just focus on one or the other. Unfortunately, in Indiana, that can be really difficult because our developmental disability system, BDDS, and our mental health system, DMHA, are pretty well siloed. They're working on getting along a little better at the state level and integrating themselves a little bit more at the state level currently. But that's new work that's just starting to happen. And so we know we've got these two fairly siloed systems. And so it could be really difficult to get that well-rounded picture of an individual that we're serving because our systems don't always work together. You guys work in IDD, so I won't spend a whole lot of time talking about what that is, but it does include some functioning deficits, and predominantly those need to happen in 3 different domains: a conceptual domain such as language, reading, writing; the social domain, our empathy skills, our social judgment, our communication skills; or a practical domain. And then of course that happens at different levels. We got that mild, moderate, severe, and profound. I always find it interesting to see this graph of like how that kind of breaks down, and when we're looking at the population of IDD individuals. And I think, in our systems, we forget that because a lot of our resources and a lot of our time have to go into caring for more of the severe and moderate and profound individuals, that sometimes we feel like maybe those numbers are larger than they really are. So it's important for us to just kind of keep in mind that in the world of IDD, that's sort of how that breaks down. Tons and tons of causes for intellectual or developmental disabilities. They kind of break into different categories, but in 2013, some research that was done really indicated that there are over 1,200 different causes. And while it's nice to know the etiology or the reason kind of behind the developmental disability issue, we don't always have that information, and we can't always figure out which of the 1,200 different reasons that it could be that it is. When we can, it's good, because that gives us some information about phenotypes or characteristics that kind of go together with that reason or that cause. So just like we kind of know that there's a certain appearance phenotype for an individual who is diagnosed with Down syndrome, we also know that there are certain behavioral phenotypes for some of these IDDs. And so when we're looking at the difference between, is this the IDD issue or is this a mental health issue, when we can trace that etiology, it really does help us to figure out, okay, if this is Fragile X or if this is Prader-Willi and the individual eats all the time, that's not necessarily a maladaptive behavior that I need to be concerned about being a mental illness. That's a part of the behavioral phenotype of Prader-Willi syndrome. So when we can identify that etiology, it's nice to have that. It's just not always available. Kind of as we then look at mental health problems versus mental illness, the way that I kind of think about this is similar to having the common cold versus having chronic obstructive pulmonary disorder. So, the symptoms may look very similar, right? I may cough, I may have some chest congestion, I may have some shortness of breath, but that cold or that chest cold, bronchitis, whichever, is going to get better in a week or two. That chronic obstructive pulmonary disorder is really going to require some medication and some behavioral changes to help me manage it rather than completely be cured from it. And as we talk with families about mental health, it is generally helpful to tie it to things that they may already feel more comfortable with, or they may already have a better understanding of, right? So sometimes I talk about it, mental health issues like diabetes, where we've got some genetic, some biological, some environmental things that have all come together for this diagnosis of diabetes. And while I may be able to manage that diagnosis in a way that lets me continue to live my life how I've mostly always lived my life, it does require that I have put some thought into maybe my medication or maybe some behavioral changes so that I can manage that in a really appropriate way. And also just, again, thinking about, like, sometimes it's just a cold, you know, sometimes it's just a short-term issue. And it's not that we don't seek help or support sometimes for those colds or those short-term issues, but it is, it can be a shorter term in intervention when we're just having maybe a hiccup in our mental health. So mental illness is a psychiatric condition that disrupts a person's thinking, feeling, mood, ability to relate to others, and can impair daily functioning. It doesn't discriminate. It can be any age, any race, any religion, any level of intelligence. We use a couple different diagnostic manuals to look at what type of mental illness that it would be. In the medical world, we use the ICD-10. In the mental health world, we currently use the DSM-5. And then the DMID is a diagnostic manual that works in conjunction with the DSM-5 to help us look at what might this specific mental illness look like for a person who also has IDD diagnoses. So they're kind of adjusted and help us to look at what might be going on slightly differently for a person with ID to also qualify for the same mental illness diagnosis. Yeah. One thing that I think it's really important to kind of think about in regards to mental illness is that, or wellness in general, and mental wellness for sure, is that it's a little bit like a balance scale, like as you can see on the screen here. So if on one side of the scale we're looking at adding things that are risk factors, on the other side of the scale, we would add things that are protective factors, the things that make us more likely to have some mental health challenges, or the things that protect us from those mental health challenges. So as we kind of teeter-totter on that scale, we may find that there are days or weeks where we're struggling a little bit more. If that scale becomes really imbalanced and those risk factors are greatly outweighing those protective factors, then we are probably dealing with chronic or long-term mental illness. One of the things that we have to continue to recognize is that our population, our IDD population, have some additional vulnerabilities, some things that fall into that risk category that we just need to be aware of as we work with them. So things like, you know, in our typical functioning population, it's somewhere between 1 in 4 or 1 in 5 individuals who have experienced sexual abuse, 1 in 3 to 4 individuals who have experienced physical abuse. That statistic gets a lot greater when we narrow it down to just the IDD population, and there it becomes closer to 50 to 75%, depending on the study that you're looking at, of individuals who have experienced some type of sexual or physical abuse. So we know we've got some vulnerability to trauma. That also happens because some events that a typical functioning individual may not see as a trauma may be experienced as a trauma for an individual who is struggling with IDD. So for example, when I was 4 or 5 years old, I lost my mom in a department store. She went one way, I was hiding in a clothes rack, and when I came out of the clothes rack, she was nowhere to be found. it's a thing that I remember. It's a thing that was scary, but it was also really short-lived. I went directly to the front of the store. I found a cashier and I said I lost my mom, and they took me to the customer service desk and made an announcement, and my mom appeared. I had the problem-solving skills to be able to manage that scary episode without it becoming something traumatic in my life. If I didn't have those skills, if I was struggling with that cognitive domain or that social domain of communication, and I couldn't tell the cashier what was going on, that event may have actually been traumatizing to me. And so we've got kind of dual things going on when we look at that vulnerability to trauma. We also know that for a lot of people who are experiencing IDD, we've got some attachment issues. If we look at several of the etiologies related to IDD, those individuals a lot of times end up spending some extra time in the NICU when they're born. That can get in the way of attachment. If you've got a parent who is mourning the loss of the child they thought that they would have, that can affect attachment. And when you're spending a long time in those early developmental stages, that can affect attachment. And so we've got lots of different ways that our individuals are just a little bit more vulnerable to experiencing mental health issues. And then just right now, in regards to this pandemic that we're in, that's making everybody, all of us, a little bit more vulnerable to some mental health issues. So we've got some isolation going on. We've got it's a little more difficult to have a routine. We may be not able to access our coping skills or our supports in the same way that we have done in the past. And so those things that maybe were protective factors for us, if we've eliminated some of those because we are in the midst of this pandemic, that's going to throw off that balance as well. So there are just several things vulnerability wise that I wanted to make sure that we touched on. So when we're looking at mental illness and people with IDD, we're really looking at behavior that is abnormal, that we can see as different. It shouldn't be able to be explained on the basis of that developmental delay alone, and it does need to cause some sort of significant impairment in functioning. If you ever get your hands on a DSM-5 and you flip it open, and under every single, or pretty much every single diagnosis, you will see one of the criteria is that it has to cause impairment in functioning in educational, occupational, or social domains. If it's not getting in the way of your life, then that behavior, even if it counts as a mental health or mental illness symptom, it's not problematic. So I like to pick on my brother and say, he's a very organized, some might say anal individual, and so he likes his life to be in a certain order, and he is pretty regimented on his routine and where things go in his life, and how he takes care of things in his day-to-day. But that works for him. He is a professor at a university. He runs the department. He's got a lot of stress and a lot of things to take care of on a regular basis, and that overly organized pattern that he has developed works for him. Now, if we were to throw off his balance and really change his risk and protective factors, some of those behaviors might start to become an impairment in his life. If he's so stuck to his routine that he can't adapt a little bit, and he begins missing things that he needs to to do because he has to start the routine over again. At that point, we might say, oh, okay, well, now he's struggling with his mental wellness. It looks a little bit like obsessive compulsive disorder, and those behaviors are getting in the way of his day-to-day functioning, that social, occupational, educational functioning. So these things are not that different when we're looking at individuals with IDD. What's difficult is that we don't always have a good baseline on our individuals. You know, we tend not to have known them over the course of their lifespan. And so it's hard for us to say, oh, you know, have they always had this type of behavior, or is this a change from something that happened to them at some point in their lifeline? So as we kind of look at a comparison between the two, we can see here that, you know, under that umbrella of IDD, we've got that below average ability to learn, happens before adulthood. We've got that intellectual functioning difficulty. It's lifelong. We're not going to heal from that. We tend to not always need medication, although medication can be helpful, kind of depends. And the impairments are really more social and adaptive, but the behavior is generally rational. I can kind of see how you got where you got there, even if it's not quite the right place to be. Whereas with mental illness, we're talking about inappropriate thought processes or emotions. So I might find something dangerous even though it's not, or I might get really stuck on one idea and not able to come off of that idea. It can occur at any time in a person's life. It really has nothing to do with intellect. It may be temporary, cyclical, or episodic. It usually needs to be helped with some therapy and some medication. It doesn't necessarily impact social competence. It can, and our behavior tends to vacillate between normal and irrational. Prevalence-wise, we're looking at 2 to 4, up to 44% of individuals with IDD who also have mental illness. And again, kind of as I stated earlier, a lot of recent studies are saying that that may even be higher due to the rates of trauma exposure in the IDD population. So just some signs that you would want to look for: some decrease in personal hygiene, lingering sadness, a family history of mental illness, any type of self-injurious behavior or suicidal ideation, some anxiety, panic, fright, seeing or hearing things. And that's not that like self-talk, like I need to do this now, but that that I hear a voice that isn't really there. It's not mine. So unusual sleep patterns, maybe some memory problems or changes in sleep and appetite and those sorts of things. We know that the individuals who have dual diagnosis tend also to be highly vulnerable to stress. They probably have had difficulties working in that competitive job market. So, you know, we got them something and it kind of blew up, or they are chronically not able to connect enough to even to get that employment, or they may have long periods of employment interspersed with either frequent job changes or just a job experience that went really, really poorly. Tend to have fewer wellness opportunities, and they lack some of those basic skills for everyday living. Usually there's some extreme dependency going on. A lot of individuals with mental health issues have fall into that learned helplessness category. They're very avoidant of trying new things. And so we're pretty consistently, you know, you need to help me, you need to do it for me, even if we've seen them do it independently at some point in their life. Or we seem to feel like they have the ability to do it, and there's something in their way. And then some difficulty in interpersonal relationships as well. which can result in disruptions in school or home or work or social environments. Some other things to kind of look out for would be difficulty focusing, ruminating or perseverating on one topic. They distrust themselves, have that low self-esteem, low social status, maybe have problems with some cognitive rigidity. We struggle to change from one task to another, or accepting that there's an alternate solution or shifting that focus. You're probably, you know, starting to think of certain people that you work with, right? So as we look then at, you know, what do we do now? Okay, so I've got a couple names in my mind. I've got a couple people that I'm thinking of that, you know, maybe they have something more than just that developmental or intellectual issue going on. I think it's really important for us to recognize that no one chooses to have mental health issues. It's not something we sign up for, right? And it's important that whether we're talking to the individual or the support system of an individual, we need to have some significant empathy around the idea that we are adding an additional not normal, right? So, you know, I say that because I've had tons of people in my office say to me, well, I just want my son to have a normal life or as close to normal as he can. Or I've had individuals say to me, I just wish I were normal. And while I don't love that word myself, I will say that what we want to make sure that we're doing is just having that empathy around the fact that we're bringing up something that's another challenge for someone, and they've already got challenges that they're facing, and nobody really wants another hurdle to jump over, right? And so we want to just be gentle and thoughtful about how we come to having this conversation with our families, with our individuals. We also want to recognize that the stigma for mental illness is real. It's one of the reasons that I really suggest that we start with those physical health kind of conditions, right? It's more comfortable in our culture to talk about diabetes or even cancer or chronic obstructive pulmonary disorder, COPD. We all know somebody who's probably had one of those diagnoses, and so it's a safer conversation than to talk about depression or schizophrenia or post-traumatic stress disorder. And so we want to just again acknowledge that fact, and again trying to start with those things that are a little more comfortable for a family or for an individual, to help them learn about what else we might think is going on. I really like the tactic of ask, provide, ask. So in this tactic, what we do is we ask we ask them what they already know about whatever it is that we think might be going on, you know. So if I've talked a little bit about how mental illness or mental wellness is about that balance scale, and I've talked a little bit about how, you know, just like with our physical health, if we can make some small changes, we can feel better. Sometimes with our mental health that works as well. And then I may say something like, so tell me what it is that you know already about depression or about mental health services, or about a certain agency, you know, maybe Meridian Health. And then they're going to give me an answer, and I can kind of gauge from there some of their values, what they think, how they're feeling, and from there I can reflect that back to them. Okay, so I hear that your family's had some problems with depression, and that you're really worried that you might have depression, but you don't want to be maybe like your uncle or like whoever it was in your life who struggled with that. And then we can say, you know, I'd really like to provide you some additional information about depression or about mental health services, or whatever way we're kind of approaching that. And then we can give that, if they're okay with that, can I give you this information, and then to provide some additional information. And then to follow up with another ask. So now that I've given you that information, tell me what you were thinking and feeling. Tell me what was going on as I was talking, or how did that sound to you? When we're talking about information, we've got a couple things here we can talk about, that balance of risk factors and helping factors. We can discuss that mental illness is not necessarily lifelong. We can refer to some of those prevalence statistics so people don't feel they're alone, right? If I say 40 to 50% of individuals with IDD also have a mental health challenge at some point in their lifespan, that's a pretty big number, and that helps me feel like I'm not alone, or my child is not alone in facing this other thing. Again, we can relate mental health to some other less stigmatized health needs. We can try to give as much information about programs and options, as well as the process that they go through to begin services. And then we can hopefully also share some success stories, obviously making sure to maintain confidentiality, so that we can work on increasing that hope. You know, people change behavior generally for one of two reasons. Either they fear where they're at and they need to make a change for that reason, or because they hope for the future to be better. What we know about behavior change is that those changes that happen with hope tend to last longer and tend to be more effective than any of the behaviors that change for fear, right? So, for example, you know, I try not to break the law because I really don't want to go to jail. I don't speed very much, which my husband gets, you know, picky on me about. I'm a rule follower just in general, because I have this fear of going to jail. Like, I don't want to do that. However, you know, I've worked with lots of people who have gone to jail, and they'll, you know, they come in and they'll, you know, shrug their shoulders and be like, jail's nothing. You just don't want to go to prison, right? You know, like, I'll go spend a weekend in a county lockup. Doesn't bother me. They've lost that fear. You know, they've experienced it already, and that's the thing with fear-based motivators, is that that fear will diminish over time, especially if we end up experiencing the consequence, right? Like, I have a 6-year-old, and I try not to use fear to motivate him, but, you know, every once in a while, you're going to lose that privilege. Well, especially, you know, like screens, you're going to lose your tablet, you're going to lose getting to pick the television show. The thing is that at 6 now, he's pretty well learned, okay, whatever, if I lose my ability to pick the television show, I'm just going to go over here and play with my Legos, right? It doesn't have the same impact any longer because he knows he can survive without picking the television show. And so that fear-based motivator doesn't have the same punch as it maybe once did, or it's variable. You know, some days he really wants to pick the show, other days he's like, whatever, I'll go play Legos, it's not a big deal, and I have to find something else, right, to motivate positive behavior. So if we can err on that side of hope, we're generally doing a little bit better. So as all of that kind of adds up, I wanted to share with you as well about our Meridian Health Services Connexxions program. Our Meridian Health Services is a community mental health center, as well as a federally qualified medical home, health home, which means that we work really hard to treat the whole person, to do integrated health care. That we want to make sure that we're looking at how our physical health impacts our mental health, impacts our social health, and vice versa. And our Connexxions program is an intensive outpatient program specifically for meeting those whole person health needs of individuals of all ages who have some type of intellectual or developmental issue, as well as some type of mental health challenge. We leave all of those classifications pretty vague. You don't have to come to us with pre-diagnosed things. You don't have to have an IQ of a certain range. We're open to assessing, to figuring out, to looking at that whole person and what's happened in their timeline, so that we can determine whether or not we can be helpful to you in one way or another. Another really cool thing about this program is that we are the only outpatient mental health provider in the United States who holds an accreditation from NADD, or the association, the National Association for the Dually Diagnosed. It just gives us a little bit of a stamp to say we care a great deal about the fact that we are providing quality mental health services, and that we want to hold ourselves to a level of accountability that says that we're going to continue to provide quality services. So we are currently accredited for 3 years. They will come back and, I think in 2022, and make sure that we're still doing what we say that we're doing to a level that they want to continue to accredit us at. And that's something that we are very proud of, and that we can strive to maintain as well. So our Connexxions program started in 2004, so we're 15, 16 years old now. We started in 3 counties. Today we're offering services in about 37. We've served over 6,000 people. Our current capacity is around 1,800, and approximately a third of those are children or youth, and then the rest of them are 18 or older. And again, you can see we've got that NADD program accreditation. We operate under some core philosophies, and I won't read all of them to you because there are a few, but it kind of boils down to we truly want to be person-centered. We want to engage our individuals in their own care. We want to know what their strengths are in regards to how they learn, how they cope, what their sensory challenges and needs are, where they're functioning at in their social and emotional development, and really trying to make this picture of a whole person, so that we can think about all of those things as we address their goals and their mental health challenges and needs. We provide a variety of services. So we've got individual or family therapy. We have personal health skill building. That's our main service right there. It's generally done one-on-one in the home or the community with a bachelor's level individual. We call them behavior clinicians, but we sometimes also refer to them as mental health skill builders or just health skill builders. So it's different from the behavioral, not clinicians, what do you guys call them? Behavioral consultants, that would be like a waiver service, and we're not a waiver service. So I'll talk a little bit more about that in a bit. We do, in some of our larger offices, also offer some group activities, so some hands-on experiential learning with a group of peers. We offer some case coordination, only in cases where it's needed. We do work with a variety of individuals who aren't on waivers, and so where if they're not on a waiver and they need some of that case coordination, we can do that. It's not a necessary component of our program. We do also provide psychiatric services. So we've got a hub of psychiatrists down in our Indianapolis office, and we do telepsych or some in-person psych around those 37 counties where we provide services, so that we can make sure that we are addressing medication needs, mental health medication needs as well. We can do some referrals for other assessments and treatments. We are an integrated care facility, so we do also offer primary, and we are beginning to offer now dental care as well in some of our sites. And then we also run a prevention hotline, so a 24-hour 7-day-a-week telephone line where you can talk to a Connexxions staff within 30 minutes to help solve a problem or assess a situation in the hopes that we can avoid police involvement or hospitalization, because we know that neither police involvement or hospitalization generally benefits the individuals that we're serving. We work collaboratively with several school districts and about 50 different developmental centers around the state of Indiana. We work with all functioning levels and all mental health diagnoses. We do this in people's homes, in the community, at school, at work, wherever there is a behavior challenge or some type of mental health issue occurring, we want to go there with that person. We want to see kind of what's happening. We want to try problem solve it with them and with the team, and then to coach that person through maybe making some different choices in the midst of whatever that challenge is. We do, as part of our goal to be person-centered and patient-focused, do a thing called feedback-informed treatment. And in 2019, our data indicates that 70% of our patients had a positive change in their outcome rating scale over a 6-month time frame. So the outcome rating scale is a tool that allows patients to share how they're feeling about their movement towards their goals. So they rate themselves, how they're doing individually, how they're doing in their family, how they're doing at work, if that's appropriate, and how they're kind of doing overall. And we are able to say that our patients show a positive change. Qualifying is pretty easy. You have to have some sort of IDD or notable learning challenge and some sort of mental health or behavioral challenge. And again, we don't need set diagnoses for a referral. We can do the assessment. If we can't find something, then we'll tell you, we just don't think there's a mental health issue going on here. And so we don't want to offer services to somebody who doesn't have that mental health issue. However, we can do some assessments and look for that as well. We're not waiver funded at all. So just like an individual can go to the doctor or to a dentist, and that's not going to impact their waiver funding, we are funded through that same Medicaid health insurance rather than the Medicaid waiver fund. And so we don't touch any waiver dollars to be able to provide the services that we provide. We are sometimes also funded through private insurances, your Blue Cross Blue Shields, your United Group services, your Anthems. We take those as well. If a person does not have insurance, we have navigators to help them try and get connected with some type of insurance. And if that doesn't work, we do also offer a sliding scale fee structure. And again, we do not affect those waiver funding streams, which I think is always really important, especially for those families who maybe are on an FSW and that's just not quite enough for what that family needs or what that individual needs. And so we can sometimes help fill in some gaps and be part of the team to help address those additional needs. To get services going, we need either the client or the guardian to sign a consent. We've got some forms that have to be filled out, and then we set up an intake time. And kind of depends where we're at in regards to how long that whole process takes. Some of our smaller offices, it takes a week or two, and some of our larger offices, it can all happen in one day. So it just kind of depends where you're at in order for us to be able to get those going. That's our phone number, and obviously you can get in touch with us to get services going, or if you have any other questions, you can always reach out to me as well. Amy and Paula have my contact information. I looked at your coverage map, and I can say that your entire East region, we have services in. Your North region, I think it's about half of the counties. And in your West region, it's maybe a third of the counties. We're kind of trying to expand that direction. We've got an office in Kokomo and Lafayette, and in LaPorte County, I forget what town that is. And so we're open to other places where we can serve. If you've got somebody in a county where we don't currently have services, we'd be happy to problem solve and see if there's a staff who maybe could pick that up, or if there's a group of individuals that maybe we could do intake on, so we could justify adding another staff. We're always open to new partnerships and new areas where we can bring some necessary and needed mental health services. So that's everything I have. I wanted to leave a couple minutes for questions. If you guys want to let me know if there are any.
Hey, does anyone have any questions? I've not seen any come through the chat, so we'll give you a moment to think if you've got something you want to ask about, inquire about. Good information today, helpful information, I think.
I feel like I should move the slide about how we're funded like way up, because it's always the question we get. But I see that it's already answered. So yeah, it is. It's that health insurance. I always try to kind of stay away from the word Medicaid, because people hear Medicaid and they think waiver, but it's an individual's health insurance that covers our services. So not those waiver dollars, because we know those are already stretched to the brim.
And very, very valuable.
Yes, yeah.
Do we have any other questions? Quiet bunch this morning. Are there popular meds that are used more often? Do you know? Have you found any consistency in medications that tend to work?
So what I can say is that our top 4 diagnoses are depression, anxiety, PTSD, and ADHD. And so the meds that tend to be utilized are the meds that are related to those. So a lot of antidepressants for both the depression diagnoses and the more generalized anxiety diagnoses. And then for PTSD, we can sometimes do the anxiety type medications as well. You know, there isn't really medication for PTSD. There's medication for the symptoms of PTSD.
Right.
And so we want to obviously get those individuals who have that trauma background involved with learning some more emotional regulation kind of skills, using some DBT and some cognitive behavioral therapy to help them kind of work through and process that trauma. We have several TFCBT therapists, certified therapists on our staff, and we continue to encourage people who are providing therapy to gain that certification. And then obviously for ADHD, we're looking at that kind of stimulant class predominantly.
Okay. And do you offer services in northern Fort Wayne or north of Fort Wayne in those counties?
Yes, we offer services in the 2 counties that are directly north of Allen, and then there are 2 like more counties. I want to say Steuben and wherever Angola is.
Oh, I think you've been.
Hold on, yeah, I've got your map right here, I think. There it is. Okay, so we definitely do Noble and DeKalb. We are a little stretched to get to LaGrange and Steuben, but if they're like closer on the line, or again, if there's maybe 2 or 3 or 4 individuals that we could all enroll so that we, you know, staff can get a good day of service up in that area, you know, we can definitely have some of those conversations.
Okay. And do you have therapists that are certified to do EMDR?
We do not currently have any EMDR certified therapists. We have actually been looking at a different similar therapy modality called progressive counting. Its research base is showing a little bit more effectiveness in regards to the IDD population. It also is a low need for verbal communication intervention. And so we're looking a little bit more into that currently than the EMDR. Although I do know that we have some therapists who are thinking about the EMDR as well. I just don't think we currently have any who are actually certified.
Okay, well, I don't see any other questions. We'll give it a moment here just in case.
There is a question about titration plans.
I missed that one. Yes, I have an individual that was using services with you and was placed on psychotropic medications. Do you provide a titration plan to case managers so that we can have it for the individual's service plan? I'm guessing, is that something that you can give to the individual so that they can share that with their waiver team?
Yes. Yeah, I mean, it would be specific to the doctor, but any
Right.
of our behavioral clinicians or therapists should be able to get in touch with the psych provider to say, you know, we'd love to get an idea as what you want this to look like, so that we can provide that to the individual or to anybody we have a release for. If you're struggling to get what you need, I always say, you know, like, I love our frontline staff. They're just super busy and also trying to manage, you know,
Right.
everything that you guys are trying to manage, you know, like adjusting to telepsych world and what can we do in person and what can we not do in person, and things do sometimes fall through the cracks. So I say never, like, don't feel like you're going above somebody's head and somebody's going to get in trouble if you reach out to the practice manager or any of the managers on our teams. You know, we want to support our frontline staff, and if they, you know, have forgotten to do something and we can help them get that taken care of, we're happy to do that. And all the way up to me. You know, if you're not getting what you need, let me know. Let the local managers know, and we will make sure that we address that.
Okay. Well, no other questions have come in, and I don't want to take up too much more of your time. We're almost at 11. Definitely appreciate your time this morning. Thank you so much for joining us. So I guess we'll go ahead and end it. Again, a thank you for attending email will go out to everyone who attended. And we appreciate your time. Thank you, Jessica.
Thank you so much.
Everyone have a great weekend.